Good evening, all. I, Shreya from Torrent Pharma, welcome you all to the Spine series, a noble endeavor by the team of Stavya spine surgeons. Thank you all for taking out time from your hectic schedules and joining us live today. Before we move forward, let me take you through the legend of Stavya. Stavya literally stands for Lord Krishna, the first spine doctor in the world. He treated Kubja, a hunchbacked woman from Mathura. The legend says that Kubja was a hunchbacked woman who once crossed paths with Krishna in the lanes of Mathura. She offered him sandalwood paste. Overwhelmed with the devotion, Krishna pressed his foot on her toes and lifted her chin with 2 fingers. It is said Kubja stood straight. The name Stavya has henceforth continued. With similar passion, Stavya stands today helping thousands of patients lead a better life. The Spine series is an educational effort in the same direction. Today is the 6th webinar of the series for us, the topic being Advances in Spine Surgery. The emergence of advanced spine surgery techniques has helped the doctors to perform miracle surgeries with accuracy. This leap has taken patient management involving complex procedures to be executed with precision. The perks being minimal invasion, multidimensional imaging, reduced complications, smaller scars, faster recovery, and a shorter hospital stay. Science has come a long way. Standing at the end of a tunnel, this tunnel, which is also the beginning of yet another advanced era of technology. The possibilities today are infinite. To understand the same, today we have an expert panel with us who shall be sharing their wealth of experience on advanced spine surgery techniques with us. Before we begin the program, let us welcome our esteemed moderator for the day, Dr. Bharat Dave. Welcome, sir. Dr. Bharat Dave is a renowned spine surgeon from Gujarat. Dr. Dave is currently the director of Stavya Institute and Hospital. Dr. Dave holds more than 30 years of experience in the field of surgery. He is an eminent speaker at all the national and international forums. Dr. Dave has also been the reviewer for many reputed journals like the Journal of Orthopedic Trauma, the Indian Spine Journal, the Asian Spine Journal, and the Global Spine Journal. I welcome Dr. Bharat Dave to today's program and hand over the session to him to kindly take us forward. Thank you.
This is purely an educational activity, not for any promotion or for advertisement, and it is based on the personal experience. Good evening, viewers. I welcome you all in the series of Stavya Spine webinars. These are purely educational webinars meant for the education of doctors, and today's topic is on advances in spine surgery. How the gadgets, the newer equipments has given us the precision, safety and accuracy that is going to be discussed in next 1 hour. Guess what this is? Is it not clear that there is something which is a big equipment and that has been loaded onto the aircraft? This is 5 MB storage, and it is something which is called supercomputer, and now we have 8 GB memory stick and we can put it in our pocket. So that is how the world started having the computer in 1956, and similar advances have been observed in the medical science too. My training has been with the myelography. We used to do myelography on our own, and that's the picture of myelograph, where you can see the X-ray and the dye flowing. And at that time, it was the myodyl lipid soluble dye which used to remain in the dural sac forever. Now what we have is the MR myelo, and even this one is the tractography, where we can identify the tracks and the damage to the track, and we can predict a lot of things as well. So I would like to start, forget the past. Well, we cannot forget the past, but we can make our presence better, and we can live in the presence, and we can certainly build the future from the past as well. And looking at this era of my training, we started with this elbow guard. We didn't have even the lead aprons in our residency days, and we used to protect our gonads with this guard which was covered by the lead. Look at the current situation of OARM and navigation which we have at Stavya as an era of technology. We all know what is Hippocrates oath, do no harm. But with this technological era, I think what we should use is extended oath would be to do good. And we all know in this COVID era, protect ourselves first, then our surrounding. That should be the goal too. So change is the only change which is constant, and that is something which really has given us edge over the others. And we as a human, we keep changing ourselves. And the classic example in our profession has been the osteoporotic fracture. If you look at the osteoporotic fracture, the whole practice has changed because of the teriparatide, where we used to really do about 5 to 10 vertebroplasty in a month. Now we do maybe hardly one or two in 6 months. Similarly, for the fluorotic spine, tandem stenosis, and I would say multi-regional spinal stenosis, which was presented in the recent ASSI meeting, the practice has been changed completely by this bone scalpel. The thing that was taking about 8 hours, 10 hours surgery, which we are able to do in just 1.5 to 2 hours because of the scalpel. Similarly, complex territories, complex anatomy, multi-level lesions, the lesions which are inaccessible, the regions, particularly the junctional regions, occipitocervical, cervicodorsal, dorsolumbar and lumbosacral, all these regions, they are made really easily accessible, and we are able to do better surgery, safe surgery with this OARM navigation and neuromonitoring. So integrated theater spine suit, which includes all these equipments and all these gadgets in class operation theater. Just I would like to say that here the precision is necessary when margin of the error is small. And look at this, we all go into this uh, the rides, which are really dangerous, but if you look at them, they are so precise and nothing goes wrong at all. Similarly, look at the bridge which has been made, multiple bridges and one running over the other. Similarly, the Tower Bridge. I'm sure everyone is aware of this London Bridge, which is something which opens up when the ship comes in the Thames River. And Channel Tunnel. One sided, the France started digging in, from the other end, the British started digging in, and then they met in the middle when they opened up the middle part of the tunnel. So that precision is really, really important, and this technology has given us that precision. Similarly, look at this, the lucky guys, but this giraffe was not lucky, and the lightning struck that one giraffe. So I would say that I would like to be precise. So when the luck doesn't come to my way, at least I'm ready for it to handle, and that is the Ernest Hemingway. So that is something that has been written in the literature as well. So the Stavya journey has been what? Patient moved. We used to really wait for the patient to move his or her limbs after the surgery. We used to give a lot of Solrimetrol in order to prevent the neural edema and neural injury, suppose in case if we have done it. And we used to keep patient, in the neurology in the room in order to view the neurological deficit after the surgery. So this is something which has been the Stavya journey. but since last 2 years, it has completely changed. That's what we are going to discuss in this webinar. We call this as the integrated theater spine suite. These are the class 100 operation theaters, which has got the O-arm, which is a CT scan machine, navigation, which is again navigates the screws and the precise the path, and the diameter can be judged, along with the neuro monitoring. So in a small corridor, we are able to perform good surgery without neurological deficit, correction without neurological deficit too. There are calibrated instruments which are navigation instruments with the drill, midas, all the implants and screws are also navigable. So we can navigate these equipments, and that certainly gives us the precision as well. And the bone scalpel is something that cuts 1 millimeter of the bone too. So this is something that we would like to really narrate here. You can see that from the one OT you can see the other OT, and we have 3 operation theaters with the glass windows, the big glass windows in between each one of them. So we can see through and through what is happening in the other operation theaters as well. So we have dedicated staff, we have team of spine surgeons, and I would say that our heartbeats are saved because of this integrated theater spine suits, because of the technological advances. And there are certainly some limitations which we need to be aware of when we start talking about these complex surgeries. So Stavya journey, because of these equipments, we do not really wait for the patient to see that patient is moving, because we have done the neuro monitoring. We normally do not give now Solimetrol, which we used to give in most of the cases earlier in the myelopathy cases, which used to give a lot of other complications as well. We do not wait for the patient to be extubated. We start our work immediately after the skin closure is done, and the recovery time in the operation theater has also reduced post-operative. And moreover, our heartbeats are saved. And this is something, just a journey to take this O-arm machine, which is a 1000 kg weight machine, in our lift. This is something that 1 inch of the space, was just away, because it would hit the ceiling of the lift. So precision, safety, and accuracy, which was all used while shifting even. So this is our team of 5 spine surgeons, and this is the Stavyans, a sort of about 50 spine surgeons in India who have been trained at Stavya, and they all are working in India at different places. In this COVID era, we should be looking at the safety, security, and suraksha, and that is being upgraded by this O-arm, navigation, and neuro monitoring. And in this COVID era, we do the 2-spin pre and post surgery with this O-arm, so that we know exactly that the screw placement and implants are in proper position. Is my son, who is in the PPE kit, has been doing his duty, and my daughter too has been doing her duty as well with the PPE kit, and getting around and checking the patients who are at home quarantine. We at Stavya have been using the respirator with N100 filters, so that has given different perspective of the surgery as well. With this aerosol generated with the high speed equipments, we are able to protect ourselves with this N100 filters as well. We have this class 100 OT, which are sort of positively pumping the air, and certainly has got the 100 filters as well, so that controls and filters the aerosols. In this COVID era at Stavya, from 15th, after 15th of the May, we have been doing the surgery with these N100 filters and respirator. All the patients, they pre-operative go for the CT scan and RT-PCR test. 14% has been just CT positive, and 4% has been RT-PCR positive. That is our own data at Stavya. And once we have done them with the test negative, then only they get admitted. These are few more gadgets which we have at Stavya. One is the exam machine, which is a fan beam machine, which is the machine which gives us the accurate BMD, bone mineral density, along with the full body evaluation as well. This is the DXA machine, which is again digital radiographs, and this is machine which gives us the full length AP and lateral X-ray in the standing position. This is one of its kind because we are able to see the sagittal balance, and this is an equipment which is in our physiotherapy department, which is called decompression machine, and that is helpful in giving the traction to the patients who need conservative treatment and who gets the benefit because of the traction therapy as well. So let's not be the slave of our own past. Plunge into sublime sea, dive deep, swim far. So when you come back, we have the new self-respect, new power, and with an advanced experience, we should be able to overlook the old one. So let's dive into this webinar of digital and the newer advances adopted at Stavya Spine Hospital, which has made us the center of excellence.
A very good evening to everyone. I am Ravi Ranjan Rai. We all know that surgery in general and spine surgery in particular do carry some inherent risks which may vary with pathology that we are dealing with the patient factors and the technical difficulties. We cannot alter the pathology that have come across. We cannot deny any patient a treatment just because the pathology is difficult to deal with. Neither can we alter the patient factors like diabetes, obese patient, osteoporotic bones. However, the technical difficulties can be overcome with the use of enabling technology. Today, we will be discussing how technological innovations and equipments are making spine surgery safer. I will be talking about ultrasonic bone scalpel and high speed burr. Ultrasonic instruments were first introduced in dental surgery in 1950s, 60s. It has also been used in neurosurgery for aspirating tumors. Ultrasonic bone scalpel was introduced in spine surgery in the last decade, but its use became common only during the present decade. Here we are dealing with a pathology where we can see spinal cord compression in the cervical spine as well as the entire thoracic spine. This is multi-level compression and this patient presented with quadriparesis. Another such case where there is a compression in the cervical spine due to OPLL, ossified posterior longitudinal ligament, and we can see in the cross section there is very minimal space available for the cord, and the calcified portion occupies a large proportion of the cervical cord canal. These are cases where surgery is associated with post-operative worsening of neurology in 15 to 20% of cases. A very high level of precision and safety is required in these kind of pathologies. And this is where the role of ultrasonic bone scalpel has come. This instrument uses the ultrasonic energy, the ultrasound energy, which translates into back and forth micro movement of the of the bone scalpel blade. And this is the blade of the bone scalpel. It also has an instrument which is an angulated burr for precise ablation. So this cuts the bone scalpel like you cut the cake with a knife. with that much precision, although it's not as soft as that and depends on what is the hardness or the quality of the bone, it would take that much time. However, the cut is very smooth, precise, and more importantly, this would cut only the hard tissue like bone, and the soft tissues under it like the dura mater or other vital structures will get displaced and will not get cut or damaged because of this instrument. That is the most important advantage. Second thing is, in those kind of compromised canals which we have just seen, we do not need to put any instrument under the lamina, so that we are not putting any extra pressure on the spinal cord, and without doing that we can accomplish the task of decompression. This picture shows how the ultrasonic bone scalpel work. This is the cervical laminectomy we are doing. This is the cranial end of the patient. This is the caudal end of the patient. And ultrasound bone scalpel is used to make a trough on both sides of the lamina like this. And then a nibbler is used to just lift the lamina. So we have not put any instrument under the lamina compressing the compromised spinal cord. And we can see the entire spinal cord is now decompressed and can be seen in this picture. So that's the main advantage, that neurological deficit and dural tear, the risk becomes very less. The other advantages is the operative morbidity decreases because the operative time decreases tremendously. There is very less blood loss, plus because we have got the bone chunk in one piece, which it can be used for graft. And because the operative time is less, the blood time is less, the blood loss is less, obviously the hospital stay will decrease. And these are all in favor of our patients, especially those very elderly and agile patients who are at high risk for surgical intervention. This is the first case that we had seen, where we had seen cervical as well as thoracic cord compression, and in this case we have been able to remove the lamina right from C2 to D12. This is the magnitude of the incision that was there. And if, frankly speaking, if we were to do this case with the older technique with bone nibbler and kerrison, it would have taken the entire day. Only because of ultrasonic bone scalpel, it was possible to accomplish this case within a few minutes. Yes, just within a few minutes, 30 to 45 minutes, this entire case was accomplished without causing any damage to the cord. And thankfully, this patient is doing absolutely well. She came with quadriparesis, but she is able to walk with support now. This is the second case that we have seen, and we have done 2-level corpectomy in this case, and we were able to smoothly accomplish this case in spite of this ossified posterior longitudinal ligament, which was possible only because of the ultrasonic bone scalpel. This is the post-operative MRI, which shows adequate cord decompression. We have certain literature as well. This paper, published in European Spine Journal in 2014, was a landmark paper regarding ultrasonic bone scalpel being used for cervical corpectomy. This was one of the first published articles regarding this. In 2019, we got another publication in Global Spine Journal, which was regarding the effectiveness and safety of ultrasonic bone scalpel in cervical laminectomy. This was a study of more than 300 patients. So as we are taught during our teaching period by the Socrates, first do no harm and do good. Now, with the latest technological advances and innovations, we need to do the best. And that is what we strive to do at Stavya Spine Hospital all the time. Thank you so much.
A very good evening to everyone. Greetings from Stavya Spine Hospital and Research Institute. I'm Dr. Devanand, a consultant spine surgeon here, and we are going to talk about navigation. As you all know, we have been using this navigation by the way of Google Maps to guide us the direction in a new place or when you are at a new place. So it guides us the target point. In the same way, it guides us the direction in which you need to go. In the same way, we have this navigation system in spine surgeries. So how this navigation system works and how is it useful to the spine surgeon, we are going to talk today. As you're all aware, the navigation system has been in use in knee surgeries to take the cuts of femoral end as well as the tibial end. In the same way, in the brain surgery, the neurosurgeons have been using it to guide the accurate placement of the tumors. In the same way, in spine, we have been using it since long. The ideal indications of this navigation system would be minimally invasive spine surgeries, deformity correction surgeries such as scoliosis, kyphosis, revision spine cases, especially in which the anatomical landmarks have been distorted, cervical spine, the high-end cases like cervical C1, C2, cervical pedicle screw fixations, tumor surgeries to check for the adequacy of tumor removal. So how this navigation system works? These are the images. On the left-hand side, you can see that the reference frame is attached to the one of the bony landmarks such as spinous process, in this case on the lumbar spine of a patient. And this reference frame has attachment of the glyons. These glyons, they see the infrared waves coming from the navigation camera. On the right hand side, you can see that the patient is placed in position and the O-arm has come inside to take the images. The O-arm is a 3D CT scan, as already been discussed by Dr. Shivanand. It takes the 3D images and the images are transferred onto the navigation screen. And after this, the navigation screen is used to guide the next steps of the surgery. It has a camera. The navigation system has a camera, as you can see there, and the infrared rays from this camera are received by the glyons on the patient. These are all the instruments: the regular entry owl, the pedicle probe, the tap, and the screwdriver. All these instruments are navigable. They have the glyon attachments on their instruments, and we can see how the system works now. This is the image. This is the case of minimally invasive spine surgery, which has been we are doing, and for L5S1, we have put the guide wires, and you can see the guide wires are put under the guidance of navigation. So the navigation screen, it shows the sagittal, coronal, as well as the axial images. So a 3D anatomy of this screen shows us the direction of the guide wire placement. There are a few examples. You can see this is a fracture spine of the dorsolumbar spine. The fractured vertebra is too much comminuted, but still, as the literature says, the screw in the fracture spine will give more stability. So the navigation system guides us to put the screw in the fractured vertebra, and we can calculate the diameter as well as the length of the screw. So we can put accurate screw in this fractured vertebra as well. With minimally invasive fixation in the fractured spine, we have minimal tissue trauma as well as the percutaneous screw placement, and the patient's pain is also less. High-end surgeries like C1, C2, which have complex anatomy, small margin of error, and sometimes we have deformities in the upper cervical spine, which have variations in anatomy. So in such cases, we have double-edged sword, like we have a spinal cord on one side and the vertebral artery on the other side. And the margin of error is very small. There is a tiny pedicle, tiny lateral mass, which lodges 3.5 mm screws So we need to be very accurate in such cases. So the navigation system, it even navigates the burr, the burr which we use to make the entry hole into the lateral mass. So we can be very accurate in such cases. In the same way, the navigation helps us to guide the extent of tumor excision. Like, as you can see on the screen, we can see the 3D anatomy on the sagittal, coronal, as well as the axial images, the extent of the tumor, as well as we can use this navigation in between the surgeries to show the depth of the tumor excision and all the margins, as well as we can take the 3D image after the surgery. So the 3D image after the surgery and the navigation point will guide us the amount of tumor we have excised, or have we left alone any of the tumor mass inside. As you all know, the tumor mass, if left alone inside, even a small piece or a small extent, it will lead to recurrence. And the recurrence is very difficult to manage in spine surgeries, as you all know. Such cases of infective spondylodiscitis with gross restriction of the vertebral bodies can also be managed in this navigation system, where you can plan the length of the screw, the diameter of the pedicle screw, as well as the defect, the length of the defect, and the amount of bone graft or the cage placement in this navigation system. So the spine surgery is evolving as the mobile networks have progressed from 2G to 3G and now 4G and 5G coming up. We, from the era of IATV, where we have only 2D images on the screen, where we have only AP and lateral images, now we have progressed to an era of 3D images, where we have three-dimensional images, where we understand the spine better. At the same time, this is all guided by technology, and spine surgery is becoming safe. So the take-home points would be 3D navigation system in collaboration with the OAM helps a spine surgeon in better understanding of the 3D anatomy of the spine. It helps us to prove improved accuracy in the screw placement. It confirms your spot. It doesn't find your spot because you need to be good in anatomy. So it confirms your spot. The only drawback of this navigation system is it has virtual images. Means you have taken a 3D image and this image is transferred to the screen of the navigation. It is a virtual image which you are seeing. That means if the spine anatomy changes during surgery, like you have a distraction or you have some changes during positioning of the screws, those small accurate things cannot be dynamically tracked. So, but still, we can say if you have safe spine surgery with this navigation system, almost 98 to 99% of the accuracy is seen with this OAM and navigation, as we have been operating this for the last 3 years. Thank you.
Good evening to all viewers. I am Dr. Shivanand Mai from Stavya Spine Hospital team. So today I am going to speak on intraoperative CT scan. So how it is taken and what are the benefits of having this intraoperative CT scan. So you all know that this is a 2D image, that is X-ray 2D image of the spinal column, and this is the intraoperative CT scan. This is the frontal plane, sagittal plane, and we get one more plane, that is axial transverse cuts. So this CT scan provides more detailed information than normal X-ray images. Even we can reconstruct these images into a 3D image and we can visualize. This is the machine, that is computed tomography machine, where the X-ray tube rotates 360 degrees around the patient and takes the images of the body, and it processes those images to give us the 3D image. So this computed tomography or computed axial tomography gives the explicit internal images of the body with the reconstruction. So this is the machine called as O-arm. It is the improved or upper version of the C-arm. In C-arm we cannot have this one 360 degree imaging. In this one the tube rotates and takes the 360 degree X-ray images. So you can see that the light becomes on, X-ray is going on. It takes X-ray images for 13 seconds, which we call as image acquisition. So this multiple X-ray shoots, and with the digital processing it gives us the images like what we usually see in spine MRI or spine CT scan, like sagittal, coronal and axial cuts. So here we have got axial cuts, coronal and sagittal. So axial is the main while inserting the screws. So this axial images we will not get in the 2D images in X-ray or C-arm images. So this CT scan combines the series of X-ray images from different angles around patient's body and uses computer processing to create the cross-sectional images, what we have said. And even we can see this 3D reconstruction before putting the screws, and we can study the anatomy intraoperatively. We can see the pedicle size, pedicle direction, okay, before inserting the pedicle screws. So once we get the images with navigation help, we can insert screws. Here we can see that there is no bone in between. So we can exactly see what is the extent of the bone and where up to where our screw should go. So we can insert the screws appropriately with these 3 images appropriately. So you can see here, this is there was a altered anatomy, that is hemivertebra. So this side 2 pedicles were present, this side only 1 pedicle was present. It was which the screw insertion was possible because of this intraoperative CT scan, so that we can see the pedicle size, pedicle direction and put the screw in correct direction because of this 3D reconstruction and imaging. So this is post screw insertion. We can confirm the screws, appropriate position, there is no breach, screws are not touching the neural tissue, and this gives us the confidence that patient is going to be fine in the post-operative period. So this is the post-operative X-ray. As you have seen already, pre-operative X-ray, the direction, in that direction with 3D imaging and with help of navigation, the screws have been put, which are fine, and patient was mobilized on the first post-operative day and patient was comfortable. So coming to the benefits of this intraoperative CT scan, it gives us a chance to better understanding of the anatomy of any patient, and intraop uses in the cases of altered anatomy, wherever you feel that the X-ray some abnormal or congenital anomaly is there, definitely this intraoperative CT scan is going to help us, and it also minimizes the screw or any implant related complications, and it mainly helps if we first surgery only, if you put the screws in proper position and if we get good hold, definitely it is going to avoid the revision surgery for those patients. So thank you for your attention.
Hello everybody, welcome to the Spine Technology webinar from Stavya. I'm Dr. Ajay Krishnan. We'll be talking about intraoperative neuromonitoring, or very simply and plainly neuromonitoring. ECG had made a lot of differences in all forms of cardiology care, and that is because it was able to detect the smallest of the conduction changes, which itself was a conduction change or multiple physiological responses to actual anatomical changes or pathological changes, and it has made drastic improvements in the cardiac outcomes and the prognostication of multiple disorders. So it is as well as diagnostic and corrective thing which the help it did. Same way our nervous system is completely interlinked with signals from brain going to the periphery and signals from periphery coming to the brain, and it is from the ventral cord that motor signals pass, and it is from the dorsal cord that the sensory signals pass, which we know very well. And this wiring is tested with the intraoperative neuromonitoring, which is a per operative investigation or monitoring diagnostic technology. This is our operation theater setup, wherein you can see the patient lying prone there. Operating surgeons, we are operating there. We have the other technologies like the O-arm there, the machines there. We have the anesthesiologist who is monitoring the physiological parameters, what we just talked about on this monitor. At the same time, we can see a hidden person, a chuporustam, jene apde kahiye, and that person is our neurophysiologist who with his computer neuromonitoring is checking the wired patient, and he is making us aware that if anything is going wrong or if any manipulation is going wrong, he will immediately bring us to notice. And this is a small system which is there, wherein there are multiple wiring which are connected to the skull indirectly to the brain. At the same time, any stimulations would just pass through the skull to the spinal cord, to the limbs, to the nerves, and the reverse way also, any stimulus from the periphery will go on to the brain. So this is what is needed, and all the components what we talked about make the team, because it's not the surgeon just does and he can get away with a very good outcome. It is not like that. TIVA, total intravenous anesthesia, that is what is the need, and that is given by the anesthetist, and it is very challenging. Inhalation agents are to be avoided as much as possible, and that makes it completely intravenous anesthesia, and it is very difficult, and there are multiple considerations to it, and the anesthesiologist needs to be experienced and trained for the same. Then is the included monitoring part what we are talking about, that is the motor evoked potentials, MEP, that is the transcranial motor evoked potentials, then is the sensory potentials, then is the D wave and the root stimulation direct. Anesthesia goals in these patients are a tight, stable hypotension. You cannot go below a hypotension of say mean arterial pressure of 55 to 60. So ideally you have to maintain above 55 to 60, otherwise it gets derailed. The neurological system itself gets derailed. Normothermia is to be maintained. The patient needs to be warmed, and there are multiple things to be done to keep the patient warmed, not just the warmer. Normal end-tidal CO2 is to be maintained. Normal volemia is to be maintained, and the HB has to be above 7 gram per deciliter. So this allows continuous functional assessment of the anatomical structures and gives us an opportunity to correct before a permanent neurological damage occurs. And this is very much important in deformity, in incomplete traumatic spinal cord injuries and SOL lesions. It is important. For sensory, somatosensory evoked potential, stimulation of the peripheral nerve is done. Impulses via the dorsal column goes to the sensory cortex. The tibial nerve is stimulated in the lower limb, and the median nerve is stimulated in the upper limb. And the red flags are any amplitude decrease of say 50% or a latency of more than 10%. along the course, because there are multiple electrodes which are connected, say in the upper limb. So if there are points which are measured, like at the stimulation point it is there, then there is the herbs point which is there, then you have the medulla level where measurement is happening, and then the cranial level. So there is any decrease in the speed of it, that means that there is something which is gone wrong. At the same time, a 2 millisecond delay also can be considered as a significant one. So transcranial electrical stimulation, that is motor evoke potential. You give stimulus at the skull level, that is transmitted from the brain, the cortex to the corticospinal tract, and that leads to muscle action potentials at the muscle level. Through the spinal cord the signals are going, and these intramuscular electrodes which are put mainly in the abductor pollicis longus and the tibialis anterior, and they give you the feedback as to whether these signals intensity and things are correct or not. There is something which additionally is there which is called D wave. These are more robust and gives more information and specific information, because by doing this you are stimulating the brain and you are collecting the information just beyond the lesion which you are operating. You are not involving the lower motor neuron, so that is more specific, called the D wave. And this is for cervical and thoracic cord. Corticospinal tract is directly recorded. You need good electrodes, it is a different form which is there. So TCMP, as we talked about the somatosensory evoke potential, red flags, the same way for transcranial evoke potentials, there is a rapid and permanent change what occurs, and that amplitude decrease is more than 50% reduction of the amplitude, or whatever stimulus you need to get that wave, that increases to 100 volt. So that is what is called as significant change. So anesthetic drugs, we need to think about and change a lot of things, and each drug has got variable actions. The degree of inhibition mainly is by the inhalation agents, that's why none of them are to be used. If at all to be used, it is better to use desflurane and sevoflurane, and the concentration, meal alveolar concentration, needs to be kept below 0.5. Nitrous oxide is most detrimental, not at all to use. Opioids, fentanyl, and the newer even remifentanil and other molecules, they all reduce the signals. It is better not to be used at all. Thiampentol, midazolam, they can be used if there is a gap in say 45 minutes, 1 hour, after which you are going to elicit something. So it is better that you don't use them, or use it very calculatively. Propofol affects the SSEP as well as MEP, and it should be only calculatively used, and if possible not at all to use. Muscle relaxants does not affect, in fact contrarily, it is going to improve the signals of the SSEP, but at the same time it is completely against the motor evoke potentials. So muscle relaxants are not to be used, or if at all is to be used in the initial part only. Ketamine and etomidate helps in the SSEP activation, but SSEP activation at the same time it is against the motor evoke, so it is not to be used. And the course of action, once you find an abnormality with the evoked potential in the spinal cord level, is that the surgeon need to reduce the correction or change the manipulation if possible, or removal of the implant if it is following that implantation which is occurred. And by the time the anesthetist is also changing this, he is changing the blood pressure, improving the HB, hypovolemia, hypothermia, the anesthesia plane has to be more lighter, IV steroid is given, and reduce the PTC, ETCO2 which is needed. So cord safety is very well monitored with this, and the sensitivity in good centers, good team, and with correct protocols goes to as high as 85 to 90%. But what about single root? If say one root is getting injured in a surgery, will it be detected? No. By these all methods, it cannot be detected a single root injury. So lower motor neuron, if you want to detect it, then the continuous EMG electromyographic discharge you need to monitor, and you can directly monitor the or directly stimulate the screws. If you have put a screw, you can stimulate the screw directly, and the signal change what occurs, or you find that on stimulating the screw, the response attained in the muscle is at say 15 milliampere, then that seems to be 98% chances of an accurately placed screws. But at the same time, if it is a malpositioned screw, then the stimulation at a current of say 10 ampere milliampere or a 200 microsecond pulse width can also give a stimulation to the muscle which is innervated. So that is where it helps the root monitoring. And many cases we have to remember that with this all getting failed in complex surgeries, we have to do a wake-up test, and that can be done, but it is negativity about it is that you don't get time to correct a damage which has occurred already, and the sensory signals may even have damaged, or you are given as dorsal cord injury without manifesting a molar injury. That is the main negativity about the wake up test. Why do you need this? The reason is very plain and simple. This is real time monitoring. We all have heard about Saturday night palsy, where a person who is not in his full consciousness, if he sleeps on a chair, he damages his he damages his radial nerve in the axilla, and results in a Saturday night palsy. The same thing works here. You have to notice it early, and if you can notice it early, because patient is completely unconscious in the anesthesia, it is only certain machines in the lighter plane which can identify if something is going wrong, and it has to give you a correct measure, correcting time, then only it can happen. The same way, on a lighter note, there are honeymoon palsies wherein you are happily sleeping, completely satisfied, and you have your radial nerve getting compressed, and this is common. This is common. This is quite common. So this is all we know in the orthopedics, and we need to have the corrective time. This is only possible if you are conscious, and the screw decompression, deformity correction, all can lead to any spinal cord damage or root damages, and it needs to be rectified timely, and has to be completely avoided for the best results. And at Stavya we have two machines, and we have indicated patients. Almost all patients can be operated under intraoperative neuromonitoring, but certain indications what we talked about, like deformity, the tumor, and the partial traumatic cord injuries that needs intraoperative neuromonitoring, experienced neuromonitorist is needed. We have 6 surgeons who are working together, anesthetist, that is a very big thing. So this is a team approach which is needed, and INM is the standard. It is the safe spine surgery standard all over the world, and everybody should demand for INM. This is the only thing which has developed in say last 10 to 20 years, and making a completely different outcome to the spinal surgeries. Say you can say this, the pedicle screws got invented in the 60s to 70s, and it has made significant contribution. The implants have evolved, but it is not changing the way the practice is there. It is the same. It is not contributing immensely, but this is again a technology. The same way as a microscope has contributed, same way this is again a technology which has immensely contributed to the outcome of the spinal cord surgery, and we all should demand and insist for our own patients and relatives for a INM monitored surgery. Thank
You all have seen and listened how these gadgets have changed our practice at Stavya. I would like to summarize what's been the goal of surgery, particularly spine surgery. Adequate decompression, nervous tissue which we really need to release from the pressure, and as and when required, we go for the internal fixation and fusion surgery, and the correction of the deformity whenever it is required. But when we use all this, what we need is implant. In order to see the implant, we usually end up with radiation and occasionally malposition of the implant as well. That can be circumvented by the newer advances in the technology which we have adopted at Stavya. We have these integrated theater spine suits as been narrated in my first talk, and that has given us a lot of. We have this staff, 5 spine surgeon, and our heartbeats are saved, as I mentioned earlier, along with some limitations which we all need to really know and identify. And our journey has been very well accepted now with the technology and the artificial intelligence, and we are able to cater and deliver and perform surgeries with safety in junctional areas, particularly occipitocervical. We are able to perform many surgeries with a lot of precision when there are no bony landmarks visible, and particularly in the redo surgery and ankylosing surgery as well. Our staff has been educated to handle these gadgets, and we are fortunate that because we have only one specialty at our hospital, so our staff is well oriented and well knowledged as well. If I give you an example of cervical spine surgeries, particularly occiput and C1 area, 2004 till date we have done about 80 surgeries, but 45 were done in last 2 years without any major mishap. So that is something which is creditable because of this O-arm and navigation. So aims are achieved, but along with that reduced learning curve, because the learning curve has been reduced with these gadgets. Anybody would argue that there will be a big learning curve because of these gadgets, but I would say on the contrary, probably somebody who wants to do with the patients, they can do surgery in any critical area with these gadgets. Basic knowledge has to be sort of applied. Avoid duplicating unwanted stage. This is very important because of the gadgets. Once you start using them, you avoid the unwanted steps. And peroperative planning, if it is done with the preoperative imaging, we are able to do it in a real short duration as well. Surgical time reduces, and the potential for the misplaced screws has gone down to practically zero. And operating time also reduced, as I mentioned, preoperative and peroperative planning if it is done properly. And practically there is no radiation at all, because when we do the spin of this O-arm, everybody goes out of the operation theater, and that gives us zero radiation. We have been using it in all the cases. As and when required, we often do the two spins as well. We occasionally use it for a lot of other sort of indications like biopsy as well. When we have to take the biopsy from a critical small space, we use it for the MISS surgery, deformity surgery, cervical posterior, redo surgeries, and high-grade fixation, high-grade lysis as well. All these surgeries are done very well with this abnormal anatomy and the anatomy which is not demarcated in the ankylosing cases and redo surgery. I would like to give certain examples, and this is a case 83-year gentleman whom we had operated earlier, and he had very good outcome. So the minute he had this fracture in his neck, he came to us and he had ankylosing spondylitis, and we were able to do safe surgery in this junctional area of cervicodorsal, and we were able to mobilize the patient immediately post-operative. So that is something which is very important and which was possible only because of the neuro navigation. 22-year gentleman, medical student, when he was operated on, he passed MBBS and now he is preparing his postgraduate exam. He had this tumor which was into the transfer process and the lateral mass of the vertebral body cervical, and it was removed en masse, and we had to put the screws because of the lateral mass which was removed. And as you can see that he has good movement as well. Another case, 14-year gentleman who had cervical hemivertebra, so congenital hemivertebra along with the dorsolumbar scoliosis as well, and this patient was operated for cervical deformity, and we were able to fix his neck from occiput to C2 C3 and correct the deformity along with the decompression of the occipital and cervical C1 C2 area where he was developing neurological deficit. Another 30-year gentleman, as you can see, there is odontoid invagination, and this patient had zero graph neuromonitoring, which was not picking up at all. And after we decompressed, after we put the screws into the occiput and C1 and also stabilized C1 C2, and patient had all the graphs which came back. So adequate decompression was the proof there as well. So all these surgeries, they give us a lot of comfort when we operate them. And these are the areas where really anything can go wrong. And if something goes wrong, we may give neurological deficit to these patients as well. So very important to have these gadgets. Radiation to the patient has always been questioned by many. Yes, I would say patient radiation is there, but it is once in the lifetime, and we certainly monitor this radiation because we go for the low dose radiation when we go for the last pin. So that is very important that we monitor for the patient as well. So Stavya had an adorable past. Its gloomy presence, well, I would say because of the corona, but yes, we are able to do a lot of good surgeries and a lot of precise surgeries with the corona negative patients as well. And we are working for the excellence too. Thank you all viewers for making our webinar successful. Our previous webinars, few of them have got viewers up to 6,000 plus. It is quite inspiring, and I request you to spread this knowledge to all friends and doctors. Good evening, viewers. On the eve of World Spine Day, we talked about the technological advances that has taken place in the spine surgery. And I think that is quite eye-opening because at Stavya, we have been using these gadgets since last few years, and it has given safety, surety, and security in the spine surgery as well. A lot of questions have come through, and I'll start with Dr. Ravi Ranjan. Dr. Ravi, I think you mentioned about the bone scalpel and it gives us the precision cuts. But is it tissue specific, Dr. Ravi?
Yes, sir. Thank you for the question. The thing is that is the beautiful thing about this instrument. It is made to cut with ultrasonic oscillations. So it cuts through hard tissue like bone or calcified material, but it will not cause any damage to underlying soft tissue like dura mater or nerves. So that's the reason it is really helpful to us.
Yeah, sure. I think what we have observed, yes, you are absolutely right, but if you stay there for a long time, then probably, it can give a little bit of blackening of the area as well. You may have observed the same as well. Dr. Ravi, you had shown that one of those cases, where the long segment decompression was done. So can you please tell me, how long did it take for you to do that long segment decompression? Because, when you do it with the drill and with the bar, it takes long time to do that. So bone scalpel?
Yeah, so that's another big advantage of bone scalpel. If we were to do the same case with the help of bone nibblers or Kerrison ronger like what we used to do before, it would have taken the entire day. It would be an 8 or 9 hours of long surgery, giving so much long anesthesia in prone position. Everything would be very high risk for the patient. While
Yeah.
in this case, we were able to complete the entire surgery in around 45 to 50 minutes, that is under an hour, which is a very big advantage for the patient in terms of less operative time, less blood loss, less risk of prone positioning, less anesthesia drugs, and plus of course the advantage of not putting anything into the already compromised and constricted canal.
Yeah.
So definitely.
Yeah, sure. I think you are absolutely right, because we are not putting any equipment into the compromised canal. And that's a statement. Yes, perfectly mentioned, that's the truth. The question to Dr. Devanand, we know that these gadgets causes radiation, gives the radiation to the patient. So is it really dangerous? And for the surgeon, do we have the radiation? Can you just elaborate on that?
Yes, sir. That's a burning question, actually, the radiation part, because much of the literature says about minimal invasive spine surgery and the dangers of radiation to the patient as well as the doctor, because in minimal invasive spine surgery or in any other surgeries, most of the shoots are taken and surgeon stands right in front of the X-ray IITV, where you take multiple shoots for each and every step. Whereas with the O-arm, the beautiful thing is once as the video shows, the O-arm is coming in and the shoot is being taken, the 3D image, we all move out, including the anesthetist, the OT staff, surgeons, everyone move out, and we stand nearly 6 feet away from the theater, the table. Yes, for everyone it is safe. For patient, we have calculated that radiation amount also. For the patient, it's once in a lifetime. And it's equal to a little bit exposure than the normal X-rays. But for the patient also, it is once in a lifetime. So it doesn't matter for the patient actually. And for the OT staff, yes. For the surgeon, yes.
Yeah, thank you. I think very well narrated, that yes, that's a big challenge, but that we have measured the dose. It's a question for Dr. Ajay Krishnan. Dr. Ajay, can you unmute yourself? And the question is the IONM. How accurate is it? Do you really rely 100% on it?
See, there is nothing as the complete accuracy which is established. This is all dependent upon a completely established team. Say, even there are machine-to-machine variabilities which are there. There are experience of the neurophysiologist also makes a difference. So even the literature says that by the time you are done with 300 cases of your neurophysiology, then only you are able to make good impressions about what is going inside this. Same way, surgeons experience, the anesthetist experience. So this also, that's why I use the term for established centers who already have had those experiences. This can nearly approach to a very handsome 92 to 100% of sensitivity, but there is nothing in this world which is near to 100% sensitivity.
Yeah, thank you, Ajay. I think there is a question related to the same. Dr. Mahapatra, he has put a question. These are the expensive gadgets, and somebody who is starting the practice, what is the advice for that particular doctor, who is starting the practice, because these are the expensive gadgets?
See, everything comes with every quality and every advance comes with a cost. If you dream of Mercedes, we have to buy it, we have to pay for it. And once you are paying it for your body, then it is definitely needed. And that's why the standard of care is changing day by day. This, so much number of complications of spine surgery which were earlier there, it has reduced significantly just because of the standardized training and the learning. Same way, this is the next level of the gadgetries which will revolutionize and make the outcomes more and more specific and more safer outcomes. So these all are for the good of the patient, and the patients have to pay the price for something they know and want to have.
Yeah. Thank you. I think just to extension to that, yes, these are the expensive gadgets, but I think they certainly adds on the ability of the surgeon. And rather than making it an expensive affair, I think we can have those gadgets at a place where everybody will use it and will become become more cost effective. There is a question from Dr. Jalaram. He is asking about the treatment of the paraplegia. Is there any treatment for the spinal cord injury? Dr. Devanand, you can answer this question.
Yes, sir. These cases of spinal cord injury, we have different ways of presentation. We have seen patients with paraparesis. We have seen patients with paraplegia. We have seen patients with quadriparesis and quadriplegia. So it all depends upon what is the diagnosis and how early the patient presents. If the patient is presenting with paraparesis with a condition in which it is treatable, yes, we do operate and we decompress the nerves and we give a chance to the patient to recover. But if the case is called transection, where the patient has presented with quadriplegia or paraplegia, yes, still now there is no treatment. We usually decompress, give the cord the space, allow it to recover. To some extent it recovers, and at the same time stabilize the patient in order for the good physiotherapy purpose. there are extensive research coming about stem cell therapy. In India, stem cell therapy is still in the research phase. It's been conducted only in very few centers. Those centers have to be government approved and the research has to be free. You cannot charge the patient for this stem cell research therapy and bluff the patient that this is going to work. You need to tell the facts, do it free, and you need to take an approval. And this stem cell, there are a lot of literature, but 100% the recovery is not guaranteed with this stem cell. It's still in the research phase.
Excellent answer, Devanand. Excellent. I think that is in nutshell what is being sort of practiced in the spinal cord injury cases. And I think the same statement is there as a white paper in the ASSI website, All India Spine Surgeon Association website. There is a question from one of the sort of Gujarati, the viewer, and he is asking about the limitations of the O-arm. You know, what are the limitations of the O-arm?
To be frank, I need to search for that because right from occiput to sacrum, S1, we get the 3D images. We get the axial, coronal, as well as sagittal images, everything at one go. And only thing is, we need to take the radiation part to the patient, and we cannot screen entire spine at once. We get 6 to 8 levels at each go, and we take one more shot after the surgery. And few cases may have, if the patient is too obese, especially cervicothoracic junction, we have some difficulty. That too, it can be manageable, but C7, T1 pedicles are little less visible when compared to other IITV. But limitations of O-arm, I could say, apart from radiation, there is no limitation as such. Yeah. Probably, sir, you might be.
Yeah, I think limitation would be only 6 and 8 segments you can see visualize at a time. But if you have more spines, then you can have the whole spine. And then you can have the sagittal balance also checked as well with the correction. Yes. Yeah, sure. Thank you. The question to Dr. Ajay, in order to use this IONM, do you really need an experienced hand, or how do you really have the sort of combination with the person who is doing this, because there has to be sort of communication constantly going on with the person who is doing the IONM.
Yes, good experience, because the interpretation is dependent.
Hello, you are not audible, Ajay.
In this, and it is very much important that there is quite a good amount of coordination and communication which is going between the team members. That includes the anesthesia person, anesthesiologist, that involves the surgeon, that involves the neurophysiologist. There are so much number of false positivities which can come. There are false negativities which can come. This all is possible if there is not perfect coordination between the whole of the team. This all is important, and this comes only with experience. It cannot go smooth in the first 50 cases to 100 cases. And even the literature says very clearly 300 cases below and above 300 cases, there is vast difference between the interpretation of the readings.
Yeah. Just to add to that, we have a checklist. If something goes wrong, that checklist is being followed, and which has been made by Dr. Ajay. That checklist is followed strictly, that these are the things that we will follow if something is observed in the IONM. Now, my last question to all the speakers. There is a sort of, question from one of the viewer as well, that we all, do you not have the fear of losing the skill because you are using these gadgets, and this gives you the virtual image. So do you have the fear of losing the skill? That is one. And along with that, what is the best of this technology which you are using, which you have in your operation theater? We start with Dr. Ravi.
Yes, sir. Thank you for the question. So, of course, not We are not losing skills because the basic skills that we have learned always comes in use. Second thing is getting a 3D orientation with OARM and navigation has only improved our understanding, our three-dimensional understanding of spine. In fact, it has improved our knowledge and understanding. That is what I believe.
Any take-home message?
It's a dream to have all these instruments together, and I think sooner or later it would become a standard of care to have all these things in a place where high-end spine surgeries or complex spine surgeries are to be performed.
Dr. Devanand?
Yes, sir. I totally agree with Dr. Ravi. It's a dream to have everything at one place, and that too, as a spine. I mean, most of the patients they ask, spine surgery means deficit. Most of them ask this question right from the way the word you ask, you tell them surgery. The first question they ask is, "Sir, will there be deficit?" So that deficit thing has nearly going to perish, because the way the ultrasonic bone scalpel has come, the thoracic, cervical, the deficits have come down. OARM navigation has helped us in putting better screws, especially minimal invasive spine surgeries. Yes, the 3D imaging and the minimal invasiveness as well as the deficit part is becoming less and less, and spine surgery is becoming more evolving with safer techniques and lesser deficits. So especially this technology would help. Yes, as IITV was once, it was not there in every theater. Now IITV is there in every theater, the 2D imaging. So yeah, probably in 5 years, the 3D would come into every theater. It should be.
Yeah.
Thank you, sir.
Thank you. Thank you. Dr. Ajay?
Yeah, these technologies will definitely improve the outcome with complications nearly approaching zero, and something which is so much rewarding that also directs us towards teamwork and bigger hospitals where people work together with all these modalities in hand. So that would be the future for spine surgery, because everything should come under one roof to be able to give the best services to the patients in the safe way.
Okay, thank you. I think I would like to conclude now. I am from the era where we had no IITV, X-rays, and now we have OARM and navigation. So I've gone through from no mobile, then pager, then mobile. We have now two mobiles or dual SIM card. So same way advances I have faced, and same way starting from epidemics to pandemic as well. So everything probably my generation has faced. Probably let's hope that we all survive 2020. I'm thankful to all my colleagues, all viewers, to make this webinar successful. This is the 6th of its kind, to more to come. I'm thankful to Torrent, and I'm thankful to Virtual Bucket as well for providing us the platform and giving us the opportunity. And Shreya Gupta and the team, Dimple, Nikunj, and Amrit Raj, and all of you, thank you for providing us this platform to share our experience with the doctors and the fellows. The conclusion would be from my end, we continue to come and share our experience in the form of case-based discussion with all our fellows, maybe from next month. After our series is over, we will have the next webinar, which is going to be next month, and which is going to be like quiz webinar. We will arrange the quiz in such a way, and we will have the active participation from all those viewers as well. So we will have the viewers, and we will have the announcement of the result at the end, who gets the best prize after we have sort of put the quiz on. So thank you all again and again, viewers and Torrent and the Virtual Bucket. Thank you. Over to Shreya, please.
Thank you so much, sir. Heartiest thank you to all the wonderful speakers for these discussions on advanced spine surgery techniques. So much to learn and so less time. Safer techniques and lesser deficits, as discussed, definitely improve the outcomes. The horizon of learning shall ever expand. Thank you all for joining us today for this Thursday evening. The knowledge karma from Stavya team shall continue. All these recordings are available on YouTube, and we shall also be circulating the link post the webinar to all of you. You all can subscribe to Stavya channel on YouTube and Facebook page also for the regular live updates. The Stavya team is continuously working on a lot of patient webinars, and the live recordings are also posted on those platforms. Today, as just briefed by Dr. Dave, it was the 6th webinar of the series for all of us. The 7th webinar is on 12th of November. Same time, the details of those shall be shared on the Stavya platform shortly. Shilcal feels immense gratitude to the entire team. A warm thank you, Dr. Bharat Dave, Dr. Ajay, Dr. Devanand, Dr. Ravi Ranjan, and Dr. Shivanand. It has been such an honor. Good night to all of you and stay safe.
Thank you.
Thank you.